So everybody, thanks for joining us. We try to do these calls every month or two. There's no real agenda. All we kind of want to do is use collective experience. This technology is so amazing and we can do so much with it and we're constantly learning. So collectively, we want to use our experiences and try to educate each other, educate ourselves, and get better at the art of what the light adjustable lens is. So I encourage everybody to just get involved. I think, Ron Carr and I were talking a little bit today. One thing I'd love to start with, I think if you're not aware, there's a Facebook page on the light adjustable lens. And it kind of brought to my, the forefront of the way I'm thinking, like how do we handle, and I'm curious how you guys do this, how do you handle patients getting improper information? The light adjustable lens, we try to control our messaging as much as we can. And I think as physicians, and this doesn't just apply to the LAL, it applies to every different facet of ophthalmology and optometry and medicine in general. Anybody have any tips, tricks? How do you control how your patients get the proper information? And if they are gathering information that might not be accurate, how do you handle that? Anybody want to jump in and kind of talk about this?
Well, we try to control it by giving the patients the information up front from our website. So I actually helped create a video. It's like about 6 minutes long, and it walks the patient through the entire process from cataract surgery all the way through the adjustments, what to expect. And we have a QR code that the surgery schedulers let the patient scan when they're scheduling for surgery. So that's like their first input of information is that whole video. And then, of course, sending them home with information specifically from our practice. So I think if you tell them it's our site, the light adjustable lens, they'll go to the website, and sometimes things can be a little different from how we do things at our practice. I do think having your own personalized information and making sure that's the first thing the patient sees, that can kind of help limit how much they're searching. But of course, you're never going to be able to limit everything the patient accesses online.
Yeah, I think the more information you can get in front of them before their visits and before their treatments, the more at ease they'll be and less likely to maybe reach for those Facebook groups and things like that. So we take it to the extent also of emailing them a fax and question, or a fact sheet of what to expect too from the time after their surgery until each day until throughout the treatments and things like that. So they know what to expect. Their vision's going to be blurry. This is going to happen, and then we also have it printed off for them because, sometimes the elderly don't really check their emails that much. So at their first visit too, we give them the same thing, but it's like a step-by-step guide. So they're there's no surprises, and they know what to expect every step of the way. So they're not second guessing, and we let them know you can have as much time as you want to test the vision so they don't feel rushed or anything like that. But also, before we start lock-ins, we have another sheet of paper we give them about explaining that red hue, a little bit of decrease in acuity, just so they're not freaking out. I think the more information you give them, the less chance they have to freak out about not knowing.
Yeah, I think it's a fine line. I encourage all my patients to do their homework, and I would do my homework as a self-admitted type A individual. I would definitely do my homework, especially if I'm paying a pretty penny for this. And so I encourage them to do their homework. I do try to be pretty direct about avoiding social media. And, we were kind of chatting a little bit before, comparing your eyes to somebody else's is kind of a fool's errand, I think. It's like me comparing my ability to play basketball to Michael Jordan. We're very different people, but we have the same parts, right? We're both humans. We have all the same parts, but we are very different. You can't compare apples to apples. We're just too different. One thing I have found, especially, this technology will draw the type A individual, the engineer types who are looking to get into the details. I will provide them with the FDA studies. And Jenny, actually, the paper you published with Dr. Folden, I've used that before, and I've given that to patients. This is a colleague of mine who does as many of these as I do. Look at it. I had nothing to do with it. It had nothing to do with this paper, so you can tell it's not baloney. I had no input in it. Use that, look at it, and then you can look at it and compare it to the FDA studies too. This was all done independently. I found that to be helpful. I think I think we're all right, providing enough opportunities for our patients to get the correct information before they jump to the Facebook, before they jump to the Instagrams or the Twitters, before they get on the forums. Because if you dig far enough in anything, you're going to find negatives. You will always find a negative. Somebody's unhappy enough to write about it. So I think that makes sense.
So for in my experience, we're like, oh, by the way, hello everyone.
Hi.
I didn't get a chance to say hi initially, but in my experience, I feel like so for like our clinic, really, we have like a dedicated team that we're like, okay, cool. Like if you're signing up to get the light adjustable lenses, these are the people that like we need to speak to, and then they give them all the brochures and everything. One thing that I like to do, especially with every single patient that I start with, is that on the first day, my first thing that I always ask them is that, like, okay, I tell them, like, look, this is the question that I ask every single patient here, and I'm about to ask you, and that is, what do you know about the light adjustable lens? Right? So I ask them straight up, tell me everything that you know about it. And you like, no matter how much information that we give them, no matter how much information that they like look up online, they can fall into one of two baskets. One is, I don't really know anything. I thought this was a good lens, expensive, so like I took it. Or B, they give me a whole spiel about like, oh, like they can do like like up to three adjustments, lock in, blah blah blah. So like it can be like a really detailed answer. Rarely is ever in between. So I feel like no matter what you do, you're still gonna really get those patients that just sign up without really thinking too much about it. And then it's up to you on day one to kind of set the standard for every patient moving forward. So that's one thing that I do for everyone on day one. Be like, okay, guys, we're starting from scratch. Whatever you read, whatever you know, let me just give you a nice little like summary of what this lens can do, what I'm going to be doing, and how, or at least what our protocol is really moving forward for the adjustments and the lock-ins. By the time the patient gets to the lock-in, and I tell them, okay, you know what, your vision is set. Your vision is great. You're doing really perfect for distance and reading, and of course, like everything in between. Now it's time for lock-in, and they're like, wait, like how many lock-ins do we have to do again? So they always forget, even though we started from scratch from day one. So it's I feel like you can educate them as much as you want, but like 50% of that information is gonna leave the moment while they leave the door. At least
I
that's
think
what
that's
my
That's a
experience.
brilliant strategy, I think. I love that. Asking them to explain it to you and then having the opportunity to kind of work through it together, not necessarily correct them and say, no, you're wrong, but work through that process together, I think starts that team aspect because this is a team thing, right? We talk about this all the time. It's a team between the OD, the MD, the surgeon, the patient, the patient's family. I think that kind of reinforces that idea, but giving them an opportunity to explain what they know. Because you're right. I mean, when I have people, when they tell me they think what they're talking about, they think they know what they're talking about. It's either very detailed and they do in fact know what they're talking about, or it's completely off, or they don't have any answer. It's the most expensive option, so I want to do it.
But sometimes, like, even when they give you like a detailed explanation, you'll find holes in it. You'll be like, oh, but they're expecting, well, like up to like six adjustments or something, well, like, for example, or like this can be adjusted over the next few years. It's like okay, right. So then I'll be like, okay, you did everything right. Just that one particular part, well, like I do want to tell you, it's not well, like over the next few years, well, like we do it like up to like three adjustments, so on and so forth, and then I get into well, like our protocol. But I do always ask them, every single patient that comes in for the first time, I always ask them, what do you know about the LAL? Tell me everything that you know, and then this way I know what they know, and if they don't know anything, regardless, we're starting from scratch from day one.
That's awesome. Anybody else have
Yeah, I
anything?
think
Yeah.
one question that I'll do with, because they do get a lot of information, right? And we all know the retention is not always there, but also we think we may be, giving them so much information that they have everything they need to make a educated decision. But I always ask, and I'm amazed after I think we've done a good job at educating them that things come up, but I'll ask them, so I know we've given you all this information. are there any questions that you have that we have not answered? And sometimes it's interesting to see what conversations come from that. So I do like asking them that question. It does, because we have in our mind what we're doing and what we're saying, but it's not always translated. They don't hear always what we think we're telling them. So,
So on the topic of misinformation, another theme on on the internet forums that I've seen recently is an accusation maybe that ODs may not be the best people to be doing this. How do you handle that? I mean, we're all ODs on this call right now, and I think we all have collectively more experience than most people doing this, and I think we're all pretty darn good at it. Anybody have any tips, or has anybody run into that hesitation by a patient where, hey, I don't necessarily want you to do this, I want my surgeon to do this? How do you handle those difficult conversations? Or have they not presented themselves?
I can't say that I've had anybody say that, hey, I don't want you doing that, or why are you doing it, not the surgeon. But the way I present it is, doctor, our surgeon is a surgeon. He is so comfortable in the OR and he has fantastic hands. I'm the optics geek in the practice. I'm the guy that spent a lot of time studying, perceptions and the lenses and the powers. I'm the one that does a lot of the physics. It doesn't always come out this way, by the way, because I don't have a rehearsed spiel, but I'll say, so we team together to create the best results, from the surgery through the adjustments and through the optics of the lens. I try to create a team approach when we're talking about, this person's going to do your surgery and I'm going to do your adjustments, because I see him at the pre-op. So I talk to him about that during the preoperative time.
Does anybody push back on you on that, Ken, at all?
I haven't had any pushback on that.
Cool.
When I talk to it that way, because I'll also, I'm going over their scans with them and stuff, and these are the stuff that the surgery team's going to use to calculate lenses to put in your eyes, and then I'm going to take over from there, and we work together. So I'm making sure they have good data going in, and then they're going to make sure I have good results to work with after. So we try to present it all the way through. Even our counselors talk about the teamwork, particularly with the light adjustable lenses.
And you're having this conversation before surgery, did you say?
Yes.
Yeah. That's the way we do it too. So we do it where I'll on some level introduce myself to patients before surgery, whether it be in the clinic at the evaluation, or seeing the patient myself, or at the very least a phone call. At the very, very least a phone call. More often than not, we're doing an in-person kind of pre-op visit, repeat measurements. We sometimes do dry eye management, trying to optimize ocular surface before surgery. That'll come through me. But I do think it introduces me to the team, and I have that exact conversation. I think the way you put it is beautiful, where I'm going through scans with the patient too, kind of to prove that I know what I'm talking about. And I don't need to show them that. I don't need to have that, but it is a bit of a, look at me, I know what I'm talking about. Here's proof. But I do think it helps, because it does get the patient who is very vulnerable. They don't know what's happening. They've never gone through this before. They get them, I think it gets them on your side, and it makes that process smoother. So I have not had any pushback either, not since early days. I mean, back in early 2000, there's a funny story Vukic and I always talk about, and maybe I've mentioned this before. It was September 2020, so we had 4 months of LAL under our belt or so at the time, and he did the first a couple, and he quickly realized, no, this is Nick's thing. Let's let Nick do the treatments. And we had one patient who was very hesitant, and I had the scarlet letter, right? She knew I was an OD. I don't want an OD doing anything. I want the surgeon. I want the MD. And he had to come in and be like, no, you really want Nick to do this. He's the expert. This is his thing. Let him do it. And kind of had to convince her. And eventually she finally caved in and said, okay, fine, he can do it. And we got to the point where she was at her final lock. And as everybody here knows, the final lock is nothing, right? The numbers, everything's already pretty much set in stone. All you got to do is do the 2-minute treatment and we're done. And my wife went into labor. And so I was going to be out for a couple of weeks with my firstborn son. And, by the time we were going to get her in was going to be about a month. And Dr. Vukic was like, well, I'll just do the lock-in, no problem. Of course, yeah, you really can't screw it up at that point. She didn't want to do it. She waited a month until I got back.
Awesome.
So it was,
Awesome.
yeah. And so that was the last time I think we had any pushback. And I think, part of the reason why we don't have pushback anymore, not only is because of how we've changed things where I'm introduced in the front end, but we've also done a lot of video work. We've also done a lot of writing. And, I think that helps when you can just inundate your patients with material that puts your face in front of them. I think that helps. Anybody else have any strategies, or anybody else have run into any issues like that? Jenny, what about you? I mean, you're at a unique situation with the co-management model or the open access model.
Yeah, I'm really lucky that all our surgeons are extremely supportive of this model. And so they pretty much introduced me on the front end as well. So like the patients are already, like, there's no even doubt, there's no other option for them. They just know that they're going to be coming to me for their treatments. But I liked Ken's suggestion there of giving that team analogy where you could take it to the another extent where it's like, if you have surgery, the surgeon does a surgery, right? But then you have rehab later. Would you want your surgeon to run your rehab and get you all? No, because that's not his specialty or her specialty. So it's like everyone on this team has their own specialty. And this is, you don't want team A doing team B's job and so forth. But I think being introduced on the front end is important, and having that support system on both sides is key.
Yeah. What about scenarios where, and I think Ken, you mentioned this earlier, maybe before we started recording, the patient who wants to go back to their referring optometrist for input in the middle of the adjustments? Because I've had people do that too. How do you handle that? Do you encourage that? Or, because I usually don't. I think that's too many cooks in the kitchen.
I think yeah, go ahead.
I've had a couple, and I've actually had one of the referring ODs to call me, and he's like, "Hey, the vision is not right. Are you sure this lens doesn't work?" And I'm like, "Dude, I don't even know why the patient went to you in the first place.
Yeah.
The treatment isn't done. Actually, this patient went to the OD. So we start our treatments 1 month after the surgery. This patient went to the OD like 2 days before his first adjustment, and he's like, my vision for distance is terrible, my reading is terrible, and then the OD's like, oh, what do you have in your eyes? Like, oh, there's something called the light adjustable lens, and the OD doesn't have too much of an experience about it. So, and then so he actually referred another patient over to us to have a refractive lens exchange. He called the other patient and said, "Oh, actually, don't don't proceed with your surgery just yet. I need to see what happens with this lens first." So this, like the OD didn't know too much, and then on top of that, he was also like imposing his will off of like poor like information onto other patients that could have had their benefit of the vision started really much earlier. So whenever a patient does tell me, I always tell them, I'm like, look, like you're in my care, right? Like I've had other ODs actually interfere with my procedure. Stick with this. When you're done with me, that's when you're gonna go see them. Doesn't matter if their office actually like calls you for the 1 month or 2 month like post-op, like you're not done. When you're done, that's when you go. So like that doesn't happen as frequently now, but it used to happen earlier. But it's just a matter of like actually counseling the patients from our team who does the surgical counseling, like and whatnot, to let them know that, hey, look, like 1 month later, instead of going back to your own OD, you're going to be coming back to us for your adjustments.
Do we think this is like a good opportunity to, get out there more and get these ODs educated, so that like, work with our peers so that they're not scared of this lens and they know more about it, whether it be at your society meetings or like if you can get, onto the local platform to do some CE or just networking for it. So more, because I know a lot of ODs that still don't know anything about this lens really. Of course, if they come in before the treatments, they're going to have, negative things to say about it. But if we don't start talking about it, out there, then it's not going to spread. But I think it's our job as the LAL providers to, continue spreading the good word.
Yeah.
Go ahead.
I agree. We're lucky enough. We actually have a liaison because we're such a referral center. We actually have an OD liaison, and she visits the different doctors that we share patients with. Mm-hmm. And she tries to educate them about the light adjustable lens. And Dr. Strange actually did one of our society meetings and spoke on it, because we realized real early on that we had to get the ODs on board with it, even just understanding the optics and the blended vision and that kind of stuff. And that's why I felt so good that I had an OD call me today saying, hey, this patient just reached out to me and you guys gave me the records. That's the other thing that's important is when they come to us and they're referred from outside for surgery after the initial pre-op appointment, I send the OD the exam and a thank you, note. Hey, we're going to proceed with surgery. And then we let them know what kind of lens that they chose. And so if they got the LAL, we let them know, hey, some of our ODs elect to do a 1 day, 1 week post-op on those, and then they send them back to us to start the treatments. So we've been able to educate our referring ODs really well, and so that smooth the transition. Because this doctor called me and goes, this patient, your office sent me the records. He's doing great. I don't know what he's complaining about. He goes, I'm just going to call him and say, you don't need to come see me. You just need to go lock in. And I'm hoping that does some good with the patient. That's literally what the referring OD said to me, because we've shared enough. And every OD, I don't hesitate to give out my cell phone number. Call me if you have a question, especially with a light adjustable lens. And when I do lock them in and they're done, I say, okay, I want you to touch bases with your doc within the next couple months. And I'm going to tell them you're coming. And I send them my final lock-in measurements. Just, hey, we're done, turning them back over to you. And here's the refractions you should find for each eye and the visual acuities, distance, intermediate, and near for each eye when they come back to you, so that you know what to expect. And that last little piece did a lot for me, because I had an OD that the patient was a year out from lock-in, doing great. She went in. Well, she had forgotten. She was so used to her LALs that she forgot there was a blend. So she was, 20/20 in the dominant eye and like 20/25 in the non-dominant. And he called me and goes, is she supposed to be? I think the lens drifted because she's like Plano and -75. I'm like, no, that's exactly how we locked her in a year ago. She just got so used to it, she forgot. He goes, oh, I said, I sent you that note. And he goes, I forgot to look at that. It was funny. But
I've seen that before too, where like, oh my gosh, they're at -1. They're not supposed to be there. No, that's exactly where they're supposed to be. That was my intent. I think communication is so important, and that we cannot say that enough. I think communication with our co-managing doctors is as important as communicating with our patient as with our surgeons. But Aditya, I agree with you. I think I don't like having my co-managing doctors involved. Once we start treatments, I don't like keeping them too involved. Because I've had patients go back to their OD to get input. And this just happened not long ago where we had an LAL plus. And, with the LAL plus, we don't typically go past -1, 1.25 at most usually. And then the OD, the referring doc, who we don't have the best relationship with, we just don't know each other that well. We're like, no, this person needs to be at 2.25. And, you should set that at 2.25. And I was like, well, no, of course not. You clearly don't know the technology. Let me do this. Yeah, that would be a very unhappy patient. So I did use it as an opportunity. I called her, and we're starting to develop that relationship, but just up to this point, we just haven't we haven't seen a lot of patients with her, so I haven't had any opportunity to work with her. But it does create a misguided mistrust, I think, with the patient, because now the patient is getting, at least for a short period of time, is getting two sets of answers. Now, my referring doc, who I've known for decades, wants me to get 2.25. You're telling me that we're not going to go past -1 or 1.25. who's right, who's wrong, and that creates that distrust. And I just don't like it. I don't like having other people involved during the process.
And
Yeah.
one thing you kind of bring up a good point, and I've run into this problem, and I'm very sensitive to the fact that, as we all know, these patients have sometimes a long-term relationship with the referring doctor. And so, here we are just coming onto the scene, and now they're, not going to go back to the doctor that they know well and trust. And so my comment typically to a patient when, they want to talk to the referring doctor is I just let them know that, look, Dr. So-and-so certainly is knowledgeable on this lens technology. However, there are nuances to this technology that, given, that our center has been doing these treatments for years, and we see a lot of patients that Dr. So-and-so doesn't have that experience. These are questions that I'm more than happy to talk to you or with you about. And if you want to talk to so-and-so, that's great, but just understand that, really he sent you or she sent you to us because we're the experts with this technology. And that seems to go over pretty well. Because I agree. I mean, some of these referring doctors just don't have enough knowledge base with the LALs, and it just ends up creating problems for us. But anyhow, so that's kind of the approach that I'll take when somebody's questioning and wanting to talk to the referring doc.
Yeah, I agree. I think it's good to include the referring doctors in like the pre and post-operative care, but in the middle of the adjustment process, I try to limit that as much as possible, just so that it's not confusing for the patient as well. But if a patient has had this long relationship with their referring doctor and they want to get their opinion, I'll typically call that referring doctor, give them a heads up, this patient's wanting to get your opinion. Here's what's going on, so they know and really fully understand the technology. Because like you said, Nick, sometimes they'll start trialing things and want to go all the way to a 225 on an LAL plus, and that just doesn't make sense with the technology. So sometimes they need our help too, and understanding the technology before they've given their opinion to the patient. Because once the patient hears that opinion, they have a longer relationship with that referring doctor. They're going to take it to heart. So I try to limit that as much as possible. When it does happen, if I can, I try to call the referring doctor and get in contact with them before. And sometimes during the adjustment process, when I do utilize the referring doctor, is if it's a referring doctor who is really familiar with the process and I've worked closely with them on it before, and we're trialing contact lenses. We don't have any contact lens trials in our practice, which I do think would be good for us to eventually acquire, but sometimes we'll utilize them for contact lens trials, and then the patient's long-term referring doctor can be involved too.
That's a good opportunity too, and we carry very few contacts. And I've mentioned on these meetings before, I don't love contact lens trials. There's different ways to skin a cat. I don't find benefit as much, but I do use them sometimes, and only in the small power increments that I carry. But if I did find the need to do that, I've got the luxury of having a wife who's an OD, so a few times I've had to go back to her and have her do the contact. But that's a good way to do that, though. I think I might steal that if I want to do that, and bring especially a new OD who is unfamiliar, give the patient FaceTime potentially with that OD and an opportunity to be excited about it in front of that OD and use it as a practice builder. That's actually probably a good strategy. I like that.
And then it forces you to get in contact with that referring doctor and share more about the technology. Obviously, we do continuing education courses at our practice, and I'll lead a lot of things in regards to that. But sometimes you don't reach out to every referring doctor, and that one referring doctor that maybe couldn't make it to meeting might be the one that's in contact with this unhappy patient or something. So it's always good to try to get involved with those referring doctors as much as possible by sending letters, like Ken said. I always try to do that at the consult, like the cataract consultation, and then I'll do it at their first adjustment, and then at their last final lock-in too. And at the final lock-in, at that last visit, I'll share the exact target so they know what to expect. I don't send correspondence throughout the adjustment process because I think that can get confusing, and then they're getting too much information, the referring doctors. But I think sending them at the beginning, what your thought process is at the beginning of the adjustments, then they can see at the very end where you ended up. is helpful for them too.
Yeah, I don't find it necessary to send correspondence every single time. I think I don't think anybody would read that, honestly. But yeah, beginning for sure, what we're doing, kind of tentative plan, then after with the refraction as, where we should be. How about, educating our referring doctors? One thing that I find to really muddy the waters a little bit is autorefraction, especially with the LAO plus or with an LAO that has negative SA induced. You can get some really wonky numbers because I've gotten phone calls like I've got this really weird like 3 diopter cylinder patient. They're seeing beautifully, but where'd this cylinder come from? Like, what was that, a refraction or like a manifest or what? No, it's just an autorefract. Oh, okay. Well, that's not real. How do you address that? Has anybody run into, I'm assuming you're all kind of giggling. You must have run into that before.
I mean, I just tell them you can't go by the autorefractor because this lens has such a deep, extended depth of focus that you're going to get a wide variety of measurements, and you can only and that's when, I'd send over the records and be like, try this prescription somewhere around here, and you'll find that it's much closer to a normal prescription.
Sometimes I just say, machines is so stupid. I just always say, look, this lens is not your typical lens. It's not a monofocal, and the autorefractor can't read it. So you're just going to get something wonky, and test it yourself. Try that. Yeah, also try this, and they're like, oh, okay, that makes more sense with their vision. I'm like, yeah.
I think we've all probably learned the hard way because I remember like early on, again, I had like a -3 +4 autorefract. What? And I remember thinking like, oh crap, like that's not good. This is bad. Why don't I just start with where I think that patient should be at -1 and go from there? Oh, it turns out, okay, that is more accurate. So again, back on the topic of the internet forums, patients who are unhappy. This is not the perfect situation. This lens is fantastic, but you're going to have the occasional unhappy. How do you calm those individuals down before they get to the internet and start speaking negatively? Anybody have any experience or thoughts? Nobody. We just have.
How many of you bring up and ask specifically, what are you having trouble seeing? Because I find that once you really shine a light on it and you're like, oh, reading. Well, if I have magazines and newspapers in my office, so I will pull one out and the lighting is normal. And I'm like, can you read it? And I find that just showing them different, working distances helps so much because they were holding it super close, 20. And then you're like, well, okay, try pushing it back. And then they realize, oh, okay. I'm like, you have a new set of eyes. You can't treat it like your old ones. You have to find your new working distance. Show them that lighting helps too. And maybe kind of just talking through and listening to them. Don't just to say, you're seeing 20/15, that's fine. Find out, okay, what in your day-to-day life are you having trouble seeing? And then they feel heard, and then you can help. Sometimes they say their cell phone. I've gotten really good, and I'm changing the setting. I physically just say, can you open up your phone, opening up settings, and then I increase the contrast, increase the font just a little bit, not that it's crazy, and then bold it as well. And those 3 things just make a world of difference. Because if you look at their phones, it's super tiny. I'm like, that's just not, I just have it on default. I'm like, their default is J1 plus or J1. It's just small. So just bumping it up a little helps them.
So, so one thing that I try to do for my patients is that, especially if they have an attendant there with them, so maybe their partner, what I like to do is I'd be like, okay, here, so Mr. or Mrs. attendant, have a seat on the chair. Right. Take a look at what the patient is able to see. And then I show them the 20/20 or the 20/15 line. Right. And then I give them the near card and I'm like, here, look, try to read this near card. And they're able to read J2, J1. And then when their partner sees what their vision, what the patient's vision is, a lot of the time I get the partner on my side, and then the partner's like, dude, your vision is fine. What are you talking about? Right? So,
That's brilliant.
so that really helps. Like that, like having their partner to be like, hey, like, do you want to see what she's seeing? Right? Or like what like he's seeing? And they're like, sure. And then they sit on the chair and I'm like, look, that's 2020. They're like, oh wow, you can read that? I'm like, yeah, well, not only that, they can also read this. And then they're like, hey, I think your vision is fine. I can't do any of this. Right. So that really helps.
That's
Yeah, I
that's
think
smart.
the biggest part, yeah, is definitely just talking to the patient, listening to them, asking truly what their issues are. A lot of times it's boiled down to working distance, like Jenny was talking about, the anisometropia in some way. Like one big comment I'll hear is like patients saying, well, when I used to drive in the past with my glasses on, I could see better than when I drive now with no glasses. And I'm like, well, remember, before cataracts, both of your eyes with glasses are seeing at the same focal distance. Now your eyes are offset a little bit. It is hard to compare to that distance vision. But a simple fix for that could be just some driving glasses in your car as needed. If you want that sharpness, and I show them what that would look like, I'm like, it's just a light pair of driving glasses only, just in the car as needed. It's just sometimes they need to hear that there is a solution and they don't mind having a pair of glasses as needed. So I find working distance, the anisometropia, or dry eye, and they're like, I'm seeing 2020 on the chart, but I don't feel like I'm seeing it. And I just have to talk to them about, I understand what you're saying. When your eyes are dry, it can feel like things aren't clear and it's frustrating. I understand where you're coming from, but this dry eye is going to get better and we will follow up with you. And I typically will follow up with those patients like 6 to 8 weeks after their final post-op. And majority of those cases, after they're done with adjustments for a while, their dry eye has settled, they're doing so much better. So sometimes if you just give them, affirmation, reassurance, and like give them kind of a timeline of when to expect the dry eye to get better, or that there's a solution like driving glasses, or they can, move their working distance or enlarge the font size on their phone, or increase the lighting in their room or their office. Just having solutions helps really relieve a lot of the patient's anxieties, I find.
You're dead on. Like 9 times out of 10, the issues are dry eye. 9 times out of 10, at least. So we routinely follow up with our patients 2 months after lock, like it was 6 to 8 weeks, like just like you said. And most of the time, 9 times out of 10, the 9 times out of 10 dry eye patients don't have any problems anymore. And I tell them too, like especially at the final lock, that hey, those symptoms, most of the time they're complaining, and they've complained 6 times already about their vision fluctuates and it's different at different times of the day. And they always seem like they have to explain it again to me. I understand. That's tear film instability. That's exactly what that is. And usually we're addressing it, at the very least, we're addressing it with preservative-free tears, but that's like toothpaste, right? That's just brushing your teeth. That's maintenance. A lot of times we will use either a light steroid pulse. I love MIBO. MIBO is fantastic for those patients. It just stabilizes everything. And more often than not, at that 2-month follow-up, they've quieted down. They're like, yeah, actually, you kind of were right. And I love that. I always, I never get tired of hearing that. You can tell me I'm right all the time. I don't mind that.
I have a question about the MIBO though. Are you getting a lot of kickback with pre-auths?
More lately, I've noticed.
Yeah,
I did not have much of an issue.
I like it, but it's annoying to have to jump through all those hoops to get them the MIBO.
Yeah, that I've run into that a lot lately, especially with medical. Oh, forget it.
Yeah, like the last month, I feel like it's changed. I don't know what the deal is, but I've gotten a lot of messages back from my staff about, costs. And I don't know what changed. I don't know.
Yeah, it's been recent for sure, where cost has increased and then pre-authorizations have skyrocketed.
Yeah.
Okay.
I do think on this topic, Jenny, you hit it on the head as far as just making sure the patient feels heard and making sure they know you're on their side when they're 20 unhappy. And most of the time, we can work through it. I had an interesting thing. This patient, she's awesome. And everywhere she goes, we did a couple adjustments. She's like, I love my distance. I love my reading, but my computer's giving me trouble. And I went, your computer? I said, interesting. That and she's showing me her phone and she's reading her phone and I'm going, why isn't that? The computer should just fall into place. And so I'm sitting there and I said, sit down at the computer for me. And I had her sit how she, woman leans right in. She's like 12 inches from the computer. And her husband goes, well, I told you you're too close. I said, oh, we're not set up for that. He said, normally your computer's further away than your phone. And it just took us sitting there going, because I'm like, I don't get why the computer's a problem. And I had her show me how she sits at her computer. I'm like, well, so her homework, she went home and adjusted her computer workstation. She's come back tomorrow and we're going to lock her in.
Guys, that'll save you the most time. If the numbers aren't, if they're seeing 20/20 distance and near and they're complaining about something, find out specifically, because they're like, I want better near. Well, what specifically are you having troubles with? And I guarantee you can either change your phone settings or find out where they're sitting on their computer. Because it's either they're sitting too far away or too close. And if you just kind of coach them through, this is where, look at, when you do this, oh, it's clear. And you do it with them in the office, it's a game changer.
Yeah, sometimes too, I'll find patients will say, well, my computer was blurry on Friday, but today was good. And I'm like, well, we adjusted you last Thursday. So your Friday was probably still getting situated, but how are things today? You know, at the office, today, were they good? And they're like, yeah. So sometimes it's asking, are you still having that issue today, or was this last week too?
Well, that makes me feel better.
So thanks all for your contributions. This has been recorded, so I'll put it up on the website. Feel free to have people look at it. I think there's always good stuff. I love these talks. I think we get so much good stuff out of it. So thanks for jumping in and contributing.
Yeah.
Have an awesome night. We'll talk to you guys all soon.
All right. Thanks. Bye, everyone.
Thanks,
Take care.
Thanks, everyone.
Have a good night.